I can ask a question.
Yeah,
maybe?
please do.
So we talk about molecular, we talk about ctDNA. We're in an early lung cancer discussion. What's the earliest stage to have molecular testing? There's talk about, should we be doing on everything, or is it really select patients can have a benefit?
Could you repeat the question?
I believe we should be doing it on everything.
Oh, sorry. So should we do molecular testing on everybody? Should everybody get ctDNA, or
Yeah,
should we
or
should be stage specific, even though stage is an abstract concept and it's based on the metric system and the ruler?
Well, it all comes down to the technology right now, and right now the technology, as you mentioned, it's not standardized, and that's the biggest obstacle right now. I think once technology catches up, then yes. But right now in the setting of clinical trials, yeah.
Maybe to follow up a question to you, Selma. I mean, one of the challenges with SBRT is that you don't have the same tumor sampling that one might get with surgery, and I was curious, interested about the data about ctDNA and recurrences. Do you think it might be all the more valuable in the setting of SBRT to consider these assays where the added value might be greater than sort of with the surgical modality, where you can do risk assessment by other means, cheaper means?
I agree completely. I do think ctDNA is the way of the future. I just think it sort of for the same reasons you mentioned. We don't always have a huge tumor sample pre-treatment, and so this could affect the ability to even do a tumor-informed assay, which might be more sensitive and could be more predictive for recurrence using ctDNA. But I do think that this is definitely the way of the future, and I think that this is kind of how we will be risk adapting patients in addition to all the features that we can see on CAT scans and pathology going forward.
Okay. Do we have a question here? Dr. Sepeschi, right up here. I don't know.
So obviously we talk about staging, we talk about all these different biomarkers, and we're all experts here. But when the patients come to clinic and we tell them that they have lung cancer, and even when we talk about stage, they ask, well, what's my 5-year survival? And this is exactly this discussion, and we spend the whole day, and we have, let's say 45 minutes with a new patient to explain to them, well, we're going to do molecular testing. If you have EGFR, we can resect, and then if you respond, then you have, and you can spend so much time. My question, I guess, is, and anybody from the panel can ask, do you think there's time for maybe some AI-generated nomogram that will take all of these factors into consideration and will generate some kind of a probability number? Because the staging is one, we use it for clinical trials, we use it to assign treatment. In that regard, you could say that stage 2 and 3 is pretty much obsolete because we assign a similar treatment. If the patient is resectable, it's resectable. If not, they go to chemoradiation. I mean, there's not such a huge difference in terms of our clinical decision making. And then there's a second part of it, which Mara and everybody else alluded to, is the response to therapy, which clearly changes some of these numbers. So it's a difficult question to answer for the patients, and yet that's the only thing that patients really care about, and it's the ultimate goal of what we do, right? We are in a time-buying business, and I would hope that we can take even some of these nuanced variables and assign some importance in an AI-generated nomogram that will give us perhaps a little bit of a better idea of where we're going.
I can respond to that. I think you answered your own question incredibly well, which is that, certainly for patients with stage 1, stage 2 disease, in our traditional anatomic definitions of stage, that that these types of nomograms could be very useful. But I really struggle when I see patients with more advanced disease to tell them, well, this is the overall survival that we see at 5 years for most patients who have multi-stage N2 disease, or this is what we see for patients with a malignant pleural effusion, because the reality is that the response to therapy really is the best predictor of their biology. And so I don't think there's anything wrong with us being honest with patients and saying, traditionally, these numbers didn't look so great. These are the numbers that we had in the past, but we have new drugs, we have new therapeutic options, we have different things that we can do right now, and I don't know what your outcome is going to be, but this is the wide range of what it could potentially be, and I think we should have this discussion in 3 months or in 6 months when we see what your response to therapy has been. And maybe someday we'll even be able to put all of those things and molecular markers that we don't yet know into a nomogram and give them that answer at the time of presentation. But like Dr. McGuire said, given our limited technology, limited information at this time, I don't think we have an AI ability to do that now until we see what their biological response is to the therapies that we're offering them.
If I can add something on that, we had this discussion at the ISLC with some members, and I think what you're raising is a very good question. How can we personalize, basically, the staging? And when you start adding feature of a tumor, then it becomes more individualized for a specific patient. And I think at some point we might think about having an app and entering specific information about not only tumor, but also ECOG, smoking, that we know have prognostic impact. And I think also the idea of being able to use the database with AI is something that we acknowledge is going to be extremely important in the future. Now it's complicated to organize, but I think the committee is really aware of that and is trying to organize that slowly for the next edition. Are we going to be able to use that? I'm not sure. But eventually, maybe for the 11th edition, that's one of the goals.
This is that, you know, there are so many of these additional variables to TNM staging. For example, visceral pleural invasion. And I sometimes struggle with some of my colleagues that I work with who sometimes interpret that even in a very early stage tumor, less than 3 centimeter, as a high risk variable and sort of would give adjuvant therapy in that setting or something like that. So I think that the more variables we have and the more people interpret them in their own way, then, you know, the treatment algorithms, especially outside of, you know, rigorous, you know, clinical setting or you know, clinical trials, people interpret these data. So having something that would say, that would then trigger you even in very early stage disease to say, hey, these are the high risk features. I think we have that in breast cancer, for example. Yeah. Women get, you know, 6 months of chemotherapy for 1 centimeter tumor because their oncotype is such that, you know, that we know that they have such a high risk for distant disease.
Okay, we have another question over here. Please introduce yourself. And,
yeah, this is Jillian Tai from Princess Margaret. Thank you for the wonderful talks. So I have a question regarding a follow-up question regarding the negative SBRT and immunotherapy trials. If we are to design the next study, because all those previously mentioned trials were in unselected patient population. So if we are to properly select patients who might benefit, you know, using other biomarkers or other metrics, what would you think would be the best patient to be selected for if we are to have another trial to answer this question?
Thank you. It's a really great question. I don't think that those trials, all of them, did have slightly different characteristics of inclusion. So Joe Chang's trial did include recurrent patients, which we know are a higher risk subgroup of patients. Potentially, this could have contributed to the better outcomes or the more substantial benefit with the addition of nivolumab to SBRT. Also, sorry, it's hard to see you from this angle, but and specifically in the SWOG 1914 study, they actually they stratified by high-risk features as well, such as PET SUV uptake, size of tumor, et cetera. So those were some features that were taken into account in designing the trial. But if I were to design the next generation of trials, knowing what we know from the Pacific trial and some of the other takeaways from the stage 3 disease, I would think that you could use a more biomarker-selected approach, or even just going more based on size, histology, some of the things we talked about. But certainly, even if you could deliver less of a dose, potentially because the tumor was central, things like that would make you think the patient was higher risk for recurrence, So potentially a combination of a biomarker-based approach as well as some anatomic or patient features. I mean, I will say that I do think ctDNA is so very powerful. We saw the plenary session at ASCO where basically an ESR1 mutation was detected by ctDNA and prompted the delivery of an ESR1 drug, the SERMs, and I feel like that was just very pivotal in the sense that we weren't even seeing progression in the patients. We were just detecting these changes that were happening in the tumor. So I do think this is kind of the way of things in the future. And unfortunately, radiation is usually the last to kind of adopt a lot of these novel techniques because we're a smaller field. But I do think we have to be at the forefront of thinking about this in the future.
I just want to pull in our two pathologists on the panel, and then I'll let you ask your question, Patrick.
We're three, John.
Oh, three. Well, yeah, right. Well, you're a moderator, but also a pathologist. The three pathologists, because it's quite distressing, your talk, Dr. Desich. So
I'm glad it was distressing.
Maybe some insights about how you foresee solving some of these challenges that you're facing on the short term, given that new trials generating these more robust data are going to take time.
Yeah, I'm sorry that was distressful. So, but this is nothing new. Let's put it this way. Our breast pathology colleagues and the entire breast community actually went through this multiple times before they actually came up with the current standardized therapy around the globe. So, as I mentioned, this is like the first time in a way that we are facing this in a clinical practice in a lung cancer. So. I think we really have to get together in a multidisciplinary setting, whatever society we decide to do that, and really come up with the evidence-based, as much as possible, grossing protocols and as well as a microscopic. I think we can assess microscopic assessment relatively easily, but standardization of grossing is really going to be difficult. And the first step would be that actually all clinical trials use the same. I think we have to sort it out within the clinical trials because it's a controlled environment. So once we sort this out and make it standardized across all the clinical trials, I think we can translate this into the clinical practice.
Okay. Any differing views from Philippe or Pierre? You guys agree? Okay.
No, we like scaring people.
Okay, go ahead.
Oh, great talks, and sorry I missed some of the earlier ones. I just wanted to ask Dr. Jabbour and also the surgeons regarding the ultracentral tumors. So presumably some of these are patients who are not fit for surgery. Some of them are patients for whom surgery might involve a pneumonectomy or a bilobectomy. Would this be a cohort where if you had a selection, you could think of some form of neoadjuvant therapy and even observation? Because they're pretty high risk, it sounds like, for SBRT at 1 year, at least in the Nordic trial. And in surgery, they're presumably high risk, whereas if you selected by PD-L1, you might have a PCR rate of over 50%. It's just a question for future trial development.
Yeah, no, it's a great question, and if you come to my talk at 12:30, you might hear a little bit about this. But in addition, I think that one could just adopt a chemo-RT approach for these ones that are, these tumors that are more centrally located or have more concern for toxicity. Obviously, the more fractions we give, as opposed to 5 going to 10 or 15 fractions, we have strong data. I had only 15 minutes to kind of cover the data, so obviously the more fractions becomes more safe. But obviously adopting a chemo-RT and Pacific approach could be one, or using your approach of delivering a neoadjuvant therapy followed by a chemo-RT approach or a more localized radiation approach could be something to be considered in the future.
Yeah, here we go.
Yes, I would like to thank all the speakers. So I don't see Dr. Jabbour because I've started the first question for her. Sorry. Hi. Do you think, my first question, do you think that the rationale for a prime immune system is still valid by using SBRT? Because when we have 2 randomized studies and shown that there is no benefit, are we doing something wrong to probably render the system like completely ineffective because 2 studies showing like no benefit? I mean, I don't know if we have the mechanism why all the preclinical study did not translate to this, your study as well, the one study presented with Atezo showing completely no benefit at all. So this is my first question, and then I will ask a question about local consolidation to Dr. Antonov, but when you finish.
Yes, I think it's really something we don't still fully understand, right? We have such a variety of data from the head and neck space to the cervical cancer space to the lung space where we're really unsure about how radiation works best in terms of timing with immunotherapy. I do still believe in the priming data. I mean, we have very strong preclinical data that founded all of these studies that told us that we could definitely prime the immune system giving checkpoint inhibitors, see a response, and get an added benefit when we gave radiation in addition. So I think it's just, but in contrast, we now have the data that too much irradiation to too many lymph nodes, sort of dampens the immune response and that we are actually sort of not benefiting patients. This was really prime for SBRT though, because SBRT is so focused. It's really hard to know. None of these studies have been published yet to know sort of to delve into the details more about the patient characteristics or certain toxicities. I think that there's still something there. I've heard even some hypotheses that you actually prime the immune system with a lot of low-dose radiation to both lungs in the 3 to 5 gray range. I've seen that as well, presented sort of behind the scenes. I just think we really don't know at this point. I think the jury's still out on what's the best way to do this. Some of the studies are looking more at neoadjuvant approaches, and I think that that could be a way to maybe sequencing is the right answer, but I still do believe in the hypothesis that these can work synergistically.
Maybe just a quick follow-up before your question, Bassam. Do you think timing, my understanding is iSaber was, you had to have your first dose of nivolumab before SBRT, which I'm not sure is the case for the 2 other studies, and then the quantity of IO. Patrick presented the 816 data with 3 doses of nivolumab in the surgical setting showing an OS benefit. So do you think that that is a contributing factor to the negativity of the studies?
Not necessarily. 867 actually did give a dose of IO before the radiation, similar to Joe Chang's data. The Atezo study with the SWOG actually gave, I think, several doses of IO before the SBRT. So, there is something there. I'm still hopeful something will kind of turn up in the data as it becomes more available and we dig into the details. But we want to figure out a way to help our patients with these therapies, and I think there's probably still a way to do it. Hopefully we haven't lost the window and the interest of the community to do this, but we've obviously seen such a benefit with the Pacific trial that I'm still hopeful we'll get there. Sorry.
That's my question for the local consolidation. So I would like to say that for the last 5 years at least, we based our foundation in practice based on Gomez trial, and we started from there where they showed local consolidation from Gomez that surgery or radiation improve in survival, and there was an update and other studies showing double survival. So slowly we're moving, and we have a lot of confusing data. We don't know which patient benefited from the local consolidation. And now in the practice, the trend is to offer after stage 4 chemo IO or some targeted therapy consolidation most of the time, the trend for surgery. So my question to you, do you have any evidence showing today that local consolidation with surgery will give better outcome for this stage 4 that you mentioned today that are responding very well to the induction? Like, do you favor any modality like surgery compared to SBRT or radiation? Because I don't see any evidence today that one modality or other is better for this stage 4. So I would like to have your view, particularly you don't believe that stage 4 matter if you have good response.
So you're asking about data comparing surgery to radiation. Am I understanding the question correctly? Okay. So we don't have any data comparing them head to head, and I honestly don't believe that we ever will have data comparing them head to head. We have looked in similar groups from the same era and the same institution at survival outcomes, and just as a comparative, comparator over a same period, we have in our institution a group of patients with a median survival after surgery that is about double that after radiation. But you can't compare those 2 groups. There's definitely apples to oranges. We are cherry picking the strongest, healthiest, youngest patients for surgery, and so it's not fair to compare the 2 groups. And so I think we are probably never going to be able to compare head-to-head the survival outcomes for the two strategies because we recognize there are differential benefits of the two strategies. Certainly, surgery comes with a greater risk, and these operations are higher complexity. They require a lot of resources beyond surgeon experience alone, a lot of institutional resources, and as well as management of some of the postoperative nuances that occur with these patients. Yet we do get really helpful data from being able to say, gee, anatomically we thought on the imaging that the pleura was involved, but in fact at this point it's not. Or this tumor that we thought isn't involved, or we thought this tumor had a complete response, but it's still 20% viable. Or this other lymph nodes that we thought were not responding at all actually are. You get a lot of important information from surgery, and I think rather than us competing surgery versus radiation, we need to continue to evaluate these patients as a multidisciplinary team and recognize that if we are truly going to turn this into a chronic disease, that patients will require both modalities over the course of their life and during the duration of their ongoing survival, and we need to figure out the right timing for both. In general, it is probably most helpful to offer surgery to the primary tumor as a first modality rather than surgery later on down the road, recognizing that we do require a little bit greater fitness for surgery than we do for radiation, but I think it can't be competing of the two modalities. The question is the patient ever going to be a candidate for surgery? And if so, then that's probably something that should be delivered earlier on, and radiation will be a complementary strategy at some point during the duration of their time. Sorry, one other nuance related to surgery versus radiation. I will say, when we talk about different systemic therapies, patients with oncogene-driven disease and have targeted therapies that work quite well are often great candidates for surgery. In patients who are highly dependent on systemic chemotherapy or other therapeutic options, systemic options that cannot be stopped for surgery or for a perioperative period of time before or after surgery without disease progression are much better suited for radiation. So I do think in that situation we need to recognize that even if there's been a tremendous response, but it's requiring dose escalation, like third, fourth, fifth line of systemic therapy, those patients are going to be harmed by stopping an effective treatment strategy for surgery, and those patients absolutely should receive radiation, not surgery.
I'm going to give Dr. Jabbour and Dr. Antonoff a break and ask Dr. Zhang. I just want to say it was probably one of the best talks I've ever heard on neoadjuvant TKI, and I think the trial designs are fascinating, and this kind of disruptive science, I think that will, really help us answer some of the questions and push the field forward. So I wanted to ask about your phase 2 trial that you showed, the NeoVade study of giving the aumolertinib followed by the chemoimmunotherapy in the EGFR mutant population. I think it's a really interesting design, and you showed some data about assessing response after the TKI portion and then the chemoimmunotherapy portion. So I guess two questions. We know that when TKI and IO are combined, like in the TATAN study, there was unacceptable signal for ILD or pneumonitis. Did you see any signals with respect to toxicity in your study, or have you seen it yet? And I guess the second question was, in your radiographic response, is that by CT, or is there a role for PET? And how does PET look different if you give a neoadjuvant TKI strategy as opposed to an IO strategy?
Thank you for the very good questions. Because from the ASCO's NeoADAURA study, even the third generation of TKI or TKI chemo, the PCR and the MPR are also very limited in the EGFR mutation. I don't think it will become the standard of care of the patient of the neoadjuvant TKI therapy for the EGFR mutation patient. So it's very controversial. And EGFR mutation patient will be divided in the two groups, I think. One is very sensitive to the TKI treatment, but the other part of the patient will be maybe very easy to resistant to the TKI treatment, including the high PD-L1 and the RB1 and RBM10 and so on. And in the clinical practice, we found that subgroup of the EGFR mutation patient, we give the TKI treatment, it will PD, got a PD, and so on. Then we think that the TKI 6 weeks and 2 weeks washout, and then IO chemo for 3 cycles may be an optional strategy. And you mentioned that the toxicity is a very important question. But in our clinical trial, no very severely stage 4 side effect was observed, but some suffering from the liver function. But the efficacy, I think that is very promising that PCR is now about 20 cases have under surgery, and the PCR is about 70%, PCR, 17%. And it's very interesting that the PD-L1 high, all the PCR occur in the PD-L1 high patient. And both the TKI and the IO chemo will make the tumor shrinkage. And I think it's very interesting.
Can,
Yeah.
Can I ask something?
Yeah, please.
So what is the percentage of PD-L1 high you find in the EGFR positive population?
Yeah, it is a good question. The PD-L1 high, including the large than 50% and 1 to 50%, 1 to 10%, and 10 to 15. I think the PD-L1 high higher than 1%, about 40%. Yes, I think it is a very important population.
Maybe just before we go to the next question, I mean, it is clear that your approach to EGFR disease is beyond sophisticated, but that presumes a level of testing that goes way beyond what we're currently doing, at least for us at McGill and probably many places around the world. What would be your standard approach from a molecular testing perspective? What assays do you require, and what depth, how many genes do you assess to be able to classify these patients in the way that you do to consider IO-based treatments?
Yeah. In the initial diagnosis, we will test for 428 genes.
Okay.
Yeah, including the RB1 and TP53, MIC, and so on.
Okay.